This second lecture in Module 9 focuses on case control studies. By now you are familiar with this schema. Case control is a type of analytic observational study. Unlike cross-sectional studies, where the exposure and outcome are ascertained simultaneously, subjects are selected based on the outcome of interest, and then past exposure is measured. The odds of exposure in those with the outcome of interest is then compared to those without the outcome of interest. For the wine drinkers in the class, I thought this was a fun analogy of the case control study design. More modest and a little bit riskier than a cohort vintage, but you don't have to wait to drink it. It's much less expensive and sometimes surprisingly good. An overview of the specific strengths and weaknesses of the design can be found on page 180 of the Merrill text, so for expediency, I won't repeat them here. It is appropriate to conduct a case control study when there is no or weak evidence supporting the exposure-outcome association of interest, when the outcome is rare, and for outcomes where medical care is sought. I will use this population-based case control study assessing the relationship between chlorinated byproducts in public water supplies and cancers of the colon and rectum to illustrate some of the key features associated with this design. The full article has been posted on Blackboard for your review. So why study chlorinated byproducts? Chlorine is a disinfectant used in Canadian water supplies. Chlorine reacts with organic material in the water and forms a mixture of halogenated and non-halogenated byproducts. The concentration and distribution of these byproducts varies depending on the treatment process and characteristics of the raw water. Some byproducts are routinely measured. There is some concern that these byproducts are carcinogenic. In a case control study, the steps to evaluating an association between an exposure and outcome involve first identifying a group of individuals with the outcome known as cases. In our example, these are individuals with cancer of the colon or rectum. Next, for the purpose of comparison, a group without the disease is identified, known as controls. Our example is a population-based case control, so these are a random sample of the population. The investigator then determines what proportion of cases and controls were exposed to chlorinated byproducts and what proportion were not exposed, creating 4 subgroups based on combined exposure and outcome status. The source population is defined to ensure cases and controls have similar characteristics, with the exception of exposure status. This is operationalized through an eligibility criteria. In our example, the source population were 30 to 74-year-old residents of Southern Ontario from 1992 to 1994. The investigators start by selecting cases from this source population based on accepted diagnostic criteria for the outcome of interest. In our example, the investigators identified cases through pathology reports with the International Classification of Disease Code for colon and rectal cancer. This data was obtained through the Ontario Cancer Registry. Other potential sources of data might be hospitals or other medical facilities, health plans, cross-sectional studies, or special populations such as the military. It's often impractical to identify cases from the general population. Ideally, case control studies only include incident or new cases of the disease. This is because the association between exposure and outcome is not influenced by living with the disease. Incident cases also enable estimation of the relative incidence of disease, but it might take time to recruit an adequate study sample, as the investigators must wait for the disease to occur. Consequently, some case control studies, especially those of very rare diseases, use prevalent cases. This is practically easier as cases are already available for study. Although incidence rate cannot be calculated, the prevalence of outcome in the exposed and unexposed can be calculated. However, there's a risk of selection bias because it's unknown whether the observed association is due to the risk of developing the disease or survival with the disease. In our example, the investigators identified incident cases diagnosed between September 92 and May 94. The purpose of controls is to estimate the frequency and degree of exposure that would be expected if no association between exposure and outcome existed. This means that the level of exposure in the control group should represent the level expected in the source population. One must be able to measure exposure in controls in a comparable manner to the cases. And finally, that the characteristics related to exposure and outcome should be identical in cases and controls, with the exception of exposure status. The source of controls depends on how the cases were identified, cost, and facilities available, and include random or probability sample of the source population, which was the method employed in our example, where the investigators used residential telephone listings to randomly select households for participation. Other sources of controls are schools, insurance company lists, places of employment, military service, neighbourhood, schoolmates, fellow workers, best friend or siblings, and hospitalized patients, either all other patients in the hospital or other patients with specific diagnoses. Page 183 of the Merrill text outlines the advantages and disadvantages of controls from hospitals and the general population, so I'll not repeat these here. Controls may be selected so that they are similar to cases in certain characteristics, such as age and sex. This is called matching. Matching is employed as a strategy to account for confounding, but once matched, investigators cannot study the association between the potential confounders on which the cases and controls were matched and the outcome. As matching artificially makes cases more similar to controls, the observed effect size is an underestimate of the true association. Therefore, matching needs to be taken into account in the analysis. This is discussed in Merrill on page 188. Selection bias is a concern in the design of case-controlled studies. Selection bias is defined as the differential selection of cases and controls that is based in some way on the exposure status. Response bias is a type of selection bias when response rate differs between cases and controls. In hospital-based case control studies, Bergson's bias is a type of selection bias when the combination of the study exposure and outcome increases the chance that exposed cases will be admitted to the hospital. Finally, prevalence incidence bias is a concern when prevalent cases are used as the exclusion of asymptomatic, mild, clinically resolved, or fatal cases may result in a different observed effect measure than if they were included. Is selection bias a concern in our example? In this population-based case control, we might be concerned about differential response rates. We see in the results that the overall response rates to completing the questionnaire were 77 and 75% for colon and rectal cases, respectively, and 72% for the controls. So it doesn't appear that a selection bias was a concern regarding the questionnaire. However, illness, death, or lack of physician consent prevented a greater proportion of eligible cases from participating compared to controls, which may have introduced a selection bias. However, in the discussion, the investigators state that they conducted a sensitivity analysis to assess the representativeness of the cases and controls and concluded that there was no systematic selection of cases or controls according to location of residence. A key assumption when retrospectively measuring exposure in case control studies is that exposure measured at time of study is the same as when the disease process began, unless retrospective measures are available. If you read the manuscript for our example of chlorinated byproducts, you'll appreciate the complexity involved in measuring these exposures. Investigators need to not only consider if the subject was exposed, but also duration of exposure, frequency, and the intensity of the exposure. Sources of information on exposure include questionnaires, either interview or by mail, existing records such as medical records, lab tests, physical measurements or examinations, environmental measurements, or asking surrogates such as spouses or mothers. In our example, information on exposure to chlorinated byproducts was estimated by interviewing subjects on the telephone about their place of residence and usual water consumption over the past 2 years. This information was supplemented with data from municipal water treatment plants on chlorination status and byproducts. The measurement of exposure in case control studies may be affected by observation bias, such as recall bias, when cases recall exposure differently to controls, or interviewer bias, when interviewers may ask questions differently depending on whether the subject was a case or control. Is observation bias a concern in our example? The authors state that the subjects were blinded to the study question, which would minimize recall bias. However, no comment is made regarding the training of the interviewers. Misclassification is a systematic, non-random error in classifying subjects with regard to exposure or outcome status. It is due to inaccurate measurements or observation bias. There are two types, differential and non-differential. Differential or non-random is when the extent of misclassification is different between cases and controls and leads to over or underestimation of the true magnitude of the odds ratio. Non-differential is random, and the degree of misclassification is the same between cases and controls. It results in dilution of the measure of association, that is, it biases the odds ratio towards zero, and can lead to an apparent absence of an association when a true association exists. So is there misclassification in our study example? Yes, misclassification is always a concern, especially as byproduct consumption was not directly measured. You were introduced to the concept of confounding in previous modules. Confounding is a distortion in the observed association due to a third factor that is an independent risk factor for the disease, is associated with the exposure of interest, and does not lie on the causal pathway. Confounding should always be considered as a possible explanation for an observed association. Confounding can be controlled for by study design through matching, or potential confounding variables are measured and a stratified analysis or multivariate logistic regression analysis conducted. In a stratified analysis, samples are separated into categories or strata of confounding variables such as sex. Stratum-specific odds ratios are then calculated. A statistical test is performed to evaluate if the odds ratios are homogeneous, and if they are similar, a pooled odds ratio, known as a Mantel-Hansel odds ratio, is calculated. The odds ratio is the most commonly used measure of effect in case-control studies. The calculation of odds ratios has been reviewed previously in Module 6. In a case-control study, the odds ratio can estimate the relative risk if the exposure prevalence among cases is generally equivalent to exposure prevalence among all eligible cases, if the exposure prevalence among controls is generally equivalent to exposure prevalence in the source population, and if the outcome disease is rare in the population. This 2x2 contingency table shows data for males taken from Table 2 of the example paper. Using the extracted data on exposure to chlorinated byproducts in cases and controls, we are able to calculate a crude, that is, an adjusted odds ratio of 1.58. This is similar to the published adjusted odds ratio of 1.68. This tells us that in males aged 30 to 74 exposed to trihalomethanes greater than 50 micrograms per litre for greater than 35 years have a 68% greater chance of developing colon cancer compared to men who were not exposed. Effect modification, along with confounding and bias, is another key concept in epidemiology. Effect modification occurs when the direction or magnitude of an association between the exposure and outcome varies at different levels of a third factor, or known as an effect modifier. In biostatistics, this is referred to as interaction. Effect modification can be evaluated by estimating stratum-specific odds ratios to see if they differ in magnitude or direction. If they do differ, then one must also consider whether effect modification makes biological sense, or if the observation is spurious. Then, a test of heterogeneity of the odds ratio is conducted to evaluate if they are actually statistically different. If effect modification exists, it should be described and not controlled for like confounding. This is table 2 from our example paper, and we see that sex is an effect modifier, with exposure to chlorinated byproducts resulting in a higher odds of developing colon cancer in males compared to no exposure, while no effect or even a suggestive protective effect is observed in females. Finally, we will recap on the case control house red. It's an observational analytic epidemiologic study where subjects are identified based on disease status or the outcome. The selection of appropriate controls is important. Selection bias, observation bias, confounding, effect modification, and measurement error are potential threats to the validity of the study. Odds ratios are the main effect measure. Analysis can be matched or unmatched, stratified, or multivariate. There are several variants of the case control study design, the most common being case crossover studies and nested case control studies. We will not deal with them specifically in this course, but out of interest they are discussed briefly on pages 188 to 190 in the Merrill textbook.